Hello everyone, welcome to yet another session of PHYSIO TV. Myself, Dr. Komal Singh, a postgraduate musculoskeletal student at Sanchit Institute College of Physiotherapy, Pune. Today we are talking about lumbar canal stenosis and its evidence-based rehabilitation. This topic will be taken by Dr. Ankita Shejwadkar ma'am. Dr. Ankita Shejwadkar ma'am has pursued her graduation from NGM College of Physiotherapy, Navi Mumbai in 2016 and her post-graduation from VSPM College of Physiotherapy, Nagpur in 2019. She was also a gold medalist in her postgraduate time and was awarded for the same by MUHS. She is also a certified kinesiotaping and COMT practitioner. She has also published various articles on mechanical low back pain, osteoarthritis rehabilitation, hand grip strength in diabetes mellitus patient, and mirror therapy in flexor tendon injury patients. She has also worked with QI Spine for almost 1.5 years and has gained experience as a McKinsey specialist for assessment and rehabilitation. She is currently an associate professor at SIA College of Health Sciences, College of Physiotherapy, Dombivli East. We welcome you, ma'am.
So we're going to talk on lumbar canal stenosis, evidence-based rehabilitation. As we all know, stenosis is defined as narrowing or constriction of a passage of canal. So as we can see in the image, any cause that leads to reduction in the diameter of the spinal canal can lead to stenosis of the canal. On the left side, we see a healthy spine where the intervertebral discs are well intact. The space is well defined and triangular in shape. Whereas on the right side, we see a spinal stenotic spine where there is osteophyte formation, herniated disc. Along with that, there is narrowing of the spinal canal. So let's just study spinal stenosis a little more in depth. So the classification of spinal stenosis goes as, on basis of anatomical area, it is divided into cervical, thoracic, and lumbar. Lumbar stenosis being the most common, and especially at the lower lumbar level, as all the body weight and greater loads are placed on the lumbar spine. Moving forward, the next classification is on the basis of morphology. So according to morphology, spinal stenosis is classified into absolute and relative stenosis. So normally, the spinal canal diameter ranges from 12 mm to 25 mm. When it is relative spinal stenosis, the diameter ranges from 10 mm to 12 mm. If the spinal canal diameter is less than 10 mm, it falls under the category of absolute spinal stenosis. The next classification is on the basis of origin. So on the basis of origin, spinal stenosis is classified as congenital and acquired. In congenital cases, we have the achondroplastic dwarf cases or any case that has reduction in the spinal canal since birth. This can occur due to intrauterine factors such as drugs, alcohol, smoking, or any malnutrition. Whereas in acquired cases, we have degeneration of the spine where you have osteophyte formation that encroaches on the spinal canal space. Also, if there is any ligamentous laxity, this can lead to subluxation, which can further cause narrowing of the canal space. In other category, we have listhetic conditions, where there is anterior slippage of one vertebrae over the other. This causes spinal canal narrowing, especially at the level of intervertebral disc. So when there is spinal canal narrowing, this effect is known as wishbone effect. The next one we have in cases of metabolic conditions like Paget's disease or fluorosis. Fluorosis is nothing but it is like degeneration of the spinal canal where there is florid new bone formation that causes a reduction in the space. Whereas in Packett's disease, the vertebral body itself has enlargement. Due to this, it posteriorly encroaches upon the spinal canal. In also cases like post-operative or post-fusion, it has been associated with lumbar canal stenosis. Now moving forward, let's see why is this topic so important for us for this discussion. A study done in Kerala in 2020 showed that 42.2% females and 57.8% males within the age group of 18 to 90 years were positive for low back pain at commonest L4, L5 level. Out of this population, 24.8% demonstrated spinal canal narrowing and narrowing of the lateral recess, which is the most common, whereas compression of neuroforamen was demonstrated in 54.8% cases, those of disc involvement. So this develops some curiosity within us as this disease being so common, and also the fact that most of the times we don't get a favorable outcome in lumbar spinal stenosis cases. So it is important to know something more about this topic. Before going in the condition per se, let's understand some anatomical considerations. So your vertebral level or one vertebral level is divided into 3 stories. So the first story comprises of intervertebral disc and the facet joint. So if there's any canal encroachment occurring at this level, which can be due to disc bulge, disc prolapse, or facetal joint arthropathy, or facetal joint subluxation, this can cause listhetic changes which can further cause narrowing of the spinal canal. In the second story, for the lateral portion, we have the foramen. Here, if there is any capsule laxity or ligament laxity, this can encroach upon the emerging nerve root. And due to this, the patient feels radicular or peripheral kind of symptoms. In the third story, virtually there is nothing that can cause stenosis other than the top end of the pedicle, or if the lower end of superior facet undergoes hypertrophy. In such cases, lateral zone stenosis or subarticular form of stenosis can occur. So this was about anatomical considerations that we should have in picture while we diagnose a case of lumbar canal stenosis. So if we know the cause, then we can choose about the treatment for that cause. Moving forward, we can see in this image, the image A on the left side upwards is a healthy vertebrae. As you all can see, there is a triangular shape of the spinal canal with good spinal nerve root orientation and even lateral recess having good orientation. Whereas if you see the left bottom image, which shows stenosed spine, here you can see that there is a disc protrusion which is causing spinal canal narrowing from anterior direction. Posteriorly, there is ligamentum flavum hypertrophy, and laterally there is facet joint hypertrophy, which is again causing foraminal stenosis. So in this image, we can summarize that disc protrusion, ligament hypertrophy, facet joint hypertrophy are all in relation to causing spinal canal stenosis. When we see the image on the right, this is a listhetic image, anterior slippage of L4 vertebrae over L5. Here, we can see at the intervertebral disc area, there is foraminal stenosis. In the last image, this is a lateral view where we can see without any listhesis, only with disc protrusion, how it causes central canal stenosis. The next image shows us the axial view or the horizontal section of lumbar spine vertebrae. So let's study this. The A image is a normal canal which is triangular in shape with well-defined pedicle facet joint. The B image shows congenital or developmental stenosis where you can see that the pedicle area is enlarged. Because of this, congenitally or since birth, the patient has a narrow or a small size spinal canal. The C image, as we can see, is that of a degenerative stenosis. Here, we can see facettal joint arthropathy, which encroaches on the spinal canal. This further changes the shape of the canal into a trefoil shape. When we see the D image, we can see congenital or developmental stenosis along with the disc herniation. So as you all can see, the disc herniation on concavity present here. Along with that, there is pedicle widening and enlargement. The E image shows us degenerative stenosis with disc herniation. So which shows facettal joint hypertrophy along with disc herniation. And the F image shows congenital stenosis, which is superimposed with degenerative stenosis. So, originally, since birth already, the shape of this canal is small and narrow. Later, because of degeneration and facet joint hypertrophy, it has further caused narrowing of the spinal canal. Moving forwards, the encroachment are divided into two types as static encroachment and dynamic encroachment. When we talk about static encroachment, they are the ones we cannot work on. Dynamic encroachments are still where we can have at least 25 to 50% of recovery. Static encroaches are anteriorly marginal osteophytes from the body, calcified annulus with or without nucleus. Anteriorly, the dynamic encroachment can be due to bulging or lax annulus. Posteriorly, the static encroachment could be from an interned proximal margin of lamina and osteophytes at laminar attachment of ligamentum flavum, whereas the dynamic encroachment can be from buckling of the ligamentum flavum. In posterolateral direction, the static encroachment, it can be due to thickening and enlarged superior articular process and capsule at the facet joint. For dynamic, it can be lax and bulging facet capsule with synovial thickening and effusion. When we talk about pathophysiology, the mechanical canal constriction that is caused, it affects the nerve bundles that are running from the spinal canal and also the free flow of CSF, which is cerebrospinal fluid. With increased demands which are placed on the cauda equina, the body cannot satisfy the nutritional needs of the nerve roots due to mechanical constriction and the associated ischemia which is caused. Due to this mechanical constriction, arteriovenous shunts open on either side of the nerve root construction. Because of this arteriovenous shunts opening, this affects the normal neurophysiological function. This causes ectopic nerve impulses formation. This causes paresthesia and tingling in the leg and cramping in the leg. Over time or due to a long time in chronic cases, this can lead to intraneural edema and thus fibrosis ensues. So this is the overall pathophysiology of lumbar canal stenosis as to why do we have paresthesia, pain and cramping in the lower extremity in such cases. Also, with extension, the pain aggravates and with flexion, it reduces. Why is it so? The answer is here. As there is a reduced canal diameter with extension, it further increases the demand on the cauda equina, leading to this complete flow. Whereas where there is flexion of the lumbar spine or flexion of the spine, this increases the spinal canal diameter, which helps in again satisfying the nutritional needs. So that the patient is better with flexion and the patient is worse with extension. When we see investigations, the mainstay of investigation for spinal stenosis cases is MRI. When we take an MRI, there is a measurement of spinal canal stenosis, which is done by calculating the canal to body ratio. As you can see on the image on the left hand side, A is the interperpendicular distance, B is the front to back distance of the spinal canal, C is the vertebral body width, and D is the front to back measurement of the vertebral body. So when you take a ratio of AB is to CD, the normal ratio is about 1:2 or 1:4.5. Any values greater than 4.5 suggest us of stenosis. The MRI image we can see on the right hand side is the lateral section of lumbar spine. It is showing spinal stenosis at the level of L4, L5 distal level. Anteriorly, there is compression from the disc protrusion or disc bulge, and posteriorly, there is compression from ligamentum flavum hypertrophy. Moving forwards to examination, we all know the special test or the two most reliable clinical tests to diagnose a case of spinal stenosis is tooth test and bicycle test. We know that the cases of spine and per se lumbar spine, the features are quite overlapping. This is because the intricate designing of the spine, where all structures are such compressively placed with each other. Hence, it is important to very minutely, differentially diagnose such cases. The differential diagnosis for lumbar canal stenosis or back pain with any other cause can be prolapse intervertebral disc. It can be due to facet joint arthropathy or listhesis. Malignancy and infection, they generally follow the other signs and symptoms of visceral origin. Vascular claudication, which we would discuss in the next slide. Peripheral neuropathy, which can be in diabetic patients or any patients with compression of the peripheral nerves. And hip disease. When we talk about vascular claudication and neurogenic claudication, this factor is a very important factor and which is common misled. So you need to classify your patients with respect to vascular claudication and neurogenic claudication. In vascular claudication, back pain may or may not be there. With neurological claudication, it is there presently or it might be in past at some time. The leg pain which is there in vascular claudication is sharp and cramping type. It generally occurs after an exercised muscle and it generally may be unilateral. Radiation in leg pain is much rare in vascular claudication. If there is any, the radiation is from distal to proximal level. Whereas in neurogenic claudication, the type of leg pain is generally vague, radicular, or heaviness and cramping. It is either radicular in fashion, which always goes from buttock, thigh, and calf, generally occurs bilaterally. Radiation is very common in neurogenic claudication, but it is generally from proximal to distal. Aggravation in vascular claudication is walking but not standing, whereas in neurogenic claudication, aggravations are any extension type of activities which are walking or standing, and the patient is better with any kind of flexion activity. Now, when a patient walks uphill or up a slope, in vascular claudication, they are worse. This is because the energy demand of that activity is more, which causes vascular claudication. Whereas in neurogenic claudication, walking uphill, a patient is better. This is because the back is in a flexed position while the patient is walking uphill. On the contrary, when the patient is walking downhill, the patient is better with vascular claudication as much less energy is required, whereas the patient is worse with neurogenic claudication because the back is extended as we go a downhill slope. The relief of pain in vascular claudication is after you stop the muscular activity, even if you are in standing position, and it is quick, within minutes. Whereas in neurogenic claudication, the relief is only if you take or attain a flexed position, preferably lying down or sitting down. Neurologic symptoms in vascular claudication, SLR test or neurogenic examination are generally absent, whereas in neurogenic claudication, neurologic signs and symptoms are generally present. Vascular examination in vascular claudication can be absent pulse, whereas in neurogenic claudication, pulse are normal and they are present. The skin appearance in vascular claudication is generally atrophic changes, whereas in neurogenic claudication, there are no changes that are seen. So this is a summary of distinguishing characteristics between vascular claudication and neurogenic claudication. Coming to the most important part, which is the treatment. Treatment in cases of spinal stenosis are on the basis of some factors. They are severity of the clinical signs and symptoms, extent of the stenosis, nature and type of the stenosis, along with that, the presenting complaints or the prognosis of the disease. Generally, a patient who is an acute type of origin, physiotherapy exercises along with medications are the first line of choice for such patients. If the patient is not better with 3 months of physiotherapy treatment and medication, then they move towards next step, which is the epidural. If the patient is even not responding on epidural, then the patient is taken for surgical procedure. For some progressive neurological deficit cases or cases which have myotomal involvement, surgery becomes the first choice. When we talk with respect to physiotherapy treatment, we follow back exercises which favors flexion, back ergonomics, improving the strength, endurance and tone of abdominal muscles, and we provide support or lumbar corset if required in a few cases. But when we come to physiotherapy treatment, it is very important, like we know, that the prognosis is not always in a positive direction in lumbar spinal stenosis cases. Hence, it is important that we follow treatment which has shown evidence in improving the lumbar canal stenosis condition. So let's just see a few studies. So a study done in the year 2020, which was an updated systematic review titled Non-Operative Treatment for Lumbar Spinal Stenosis with Neurogenic Claudication. It reviewed RCTs published in English where at least one arm provided data on non-operative treatment and included participants diagnosed with neurogenic claudication with imaging confirmed with lumbar spinal stenosis. So this was their flowchart of recruiting articles. They in total screened 15,000 articles, from which, according to eligibility, they again narrowed down to 156 articles. For final, they included 23 new studies along with 21 studies from a previous review that they had published. So in total, this study encompassed 44 studies for qualitative synthesis and 2 studies for quantitative synthesis. So the inference of this study was that a moderate quality of evidence was seen for manual therapy and exercise. It provided superior and clinically important short-term improvements in symptoms and function when compared with medical care or community-based group exercise. Another finding of the study was that moderate quality evidence that comprehensive care included manual therapy, education, and exercise, which was delivered using cognitive behavioral approach. It demonstrated improvements in walking distance in immediate, short-term, intermediate, and even long-term when compared to self-directed home exercise. Another study which focused on the number of sessions to be taken, which was done in the year 2020, titled Therapeutic Advantages of Frequent Physical Therapy Sessions for Patients with Lumbar Spinal Stenosis. It was a retrospective study of randomized controlled trials and a prospective study of patients with lumbar spinal stenosis. The objective of the study was to identify the effects of number of physical therapy sessions on clinical outcomes of patients with lumbar spinal stenosis. The inclusion criteria of the study was presence of neurogenic intermittent claudication, pain, numbness in lower extremities with or without low back pain. Lumbar spinal stenosis, which was confirmed on basis of MRI, history of ineffective response to pharmacotherapy for more than 3 months, and age more than 50 years. The exclusion criteria was any previous spinal surgery, treatment with epidural steroid injection or selective nerve root infiltration, loss of bowel or bladder control, other comorbidities, fracture or any psychological involvement. The outcome measures included in the study was severity of stenosis. They took 7-grade classification based on morphology of the dural sac on T2 eggshell MRI of lumbar spine. For clinical outcomes, the outcome was Zurich claudication questionnaire. For low back pain, leg pain, and numbness, they quantified it using numerical rating scale and Japanese Orthopaedic Association back pain evaluation questionnaire. The overall health status was assessed using medical outcome study 36-item short form general health survey SF36. Anxiety and depression was assessed using the hospital anxiety and depression scale. Pain related anxiety was assessed using the pain anxiety symptom scale. It included 2 studies. So study 1 had a frequency of patients visiting once a week for 6 weeks. They followed treatment of manual therapy, lumbar flexion and strengthening exercises, lower extremity strengthening exercises, body weight supported treadmill walking, and home program of walking and flexion with strengthening exercises. The study 2 was divided further into 2 groups. The first group was supervised training group, which came for the clinic 2 times a week for 6 weeks, where they were given manual therapy, individually tailored stretching and strengthening exercises, cycling, and body weight supported treadmill. Home program given to these patients was walking with flexion and strengthening exercises. The second home program group, they were called on the very first day, where they were taught walking with flexion and strengthening exercises, which was done under the supervision of a therapist. Whereas for subsequent weeks, the patient was supposed to come 1 visit per week, where the therapist only monitored all the exercises and encouraged them to do their home program continuously for 6 weeks. The results of this study were in the favor that 6 weeks of supervised physical therapy twice a week resulted in significant short-term improvements in symptom severity, physical function, back and leg pain, and walking disturbances as compared to once a week or home exercise program. Also, the first group performed flexion and strengthening exercises which were not individually tailored, whereas the second group had individually tailored exercises and cycling in addition to body weight supported treadmill ambulation. Even this can be a cause of getting better results in the second. The last study that I would like to discuss is a systematic review and a meta-analysis done in the year 2021, titled Effectiveness of Conservative Non-Pharmacological Therapies for Pain, Disability, Physical Capacity, and Physical Activity Behavior in patients with degenerative lumbar spinal stenosis. The study reviewed full reports published in peer-reviewed scientific journals of randomized controlled trials of adults more than 18 years of age with degenerative lumbar spinal stenosis treated with conservative non-pharmacological interventions. They overall reviewed 2,500 articles, from which the eligible articles that were narrowed down were 41, and they included 21 cases in this systematic review, whereas 5 were taken for quantitative synthesis. The categorization of data was further taken on the basis of 4 follow-up times. It was immediate, which is less than 2 weeks of follow-up time. Short term, from 2 weeks to 3 months. Intermediate, from 3 months to 12 months. And long term, which was more than 12 months. So when they compared supervised exercise manual therapy versus self-directed or group exercise, supervised exercise and manual therapy gained superior evidence with low quality evidence on increasing short-term walking capacity and no evidence on intermediate-term walking capacity. Also, there was a moderate quality evidence on short-term improvements in back pain and leg pain in cases of supervised exercise and manual therapy. Next, when they compared multimodal rehabilitation versus surgery, surgical cases had better outcome with moderate quality evidence with a lower disability rate in long term. When they compared multimodal rehabilitation versus epidural steroid injection, it was found out that multimodal rehabilitation, including manual therapy and acupuncture, had a moderate quality level of evidence with greater intermediate term improvements in pain, disability, claudication symptoms, and walking capacity. When they compared passive movements versus sham therapy, it was found out that pulse electromagnetic field therapy had better outcomes with a low quality level of evidence for improving pain, disability, functional mobility, quality of life at immediate and short-term follow-up. Comparison between rehabilitation versus minimal treatment showed that supervised rehabilitation was superior with low quality level of evidence for improving short-term leg pain, trunk muscle strength and endurance, lumbar range of motion, and walking capacity. With multimodal treatment options, when they compared aquatic exercises versus land-based exercise and physical modalities, it was found out that aquatic exercises had better outcomes with low quality level of evidence for short-term improvements in pain and walking capacity. Whereas body weight supported treadmill walking versus cycling, when it was compared, there was no evidence seen, which shows that they both are equally effective with respect to short-term differences in disability and pain. The other two conservative treatments that gained importance in the systematic review was one with spinal traction and the second one was manipulation, which was given at the level of spine which was involved. So the inference from the systematic review is that the choice between conservative and surgical stays as a mainstay with respect to individual cases. Currently, overall low level of evidence for improvements with conservative treatment is seen. So that's how we come to an end of this lecture. I would like to summarize the whole topic in these three take-home messages. First one being choice of treatment. Choice of treatment is always with respect to individual signs and symptoms, severity of the stenosis, and prognosis. Then you should decide whether the patient should fall under physiotherapy treatment or surgical. Next, coming to physiotherapy treatment. Physiotherapy treatment should focus more on evidence-based practices. As we saw in these evidences, we could favor body weight supported treadmill walking, individually tailored strengthening and stretching exercises, aquatic therapy, and also electromodalities as and when required. The goals and management of lumbar canal stenosis patients should be working towards maintenance and prevention of the prognosis. This should be the mainstay in goals of management. I would like to end with a small quote. A milligram of prevention is worth a kilogram of cure. I would again like to thank Sancheti College of Physiotherapy for giving me this opportunity to deliver a lecture on this PHYSIO TV platform. If our viewers have any doubts, they can get back to me on the email ID mentioned on the screen. Thank you.
Thank you, Dr. Ankita Shejwadkar ma'am, for such a informative session. We all have gained a lot of knowledge from this talk. I would also like to thank our chairman, Dr. Parag Sancheti sir, our executive director, Manisha ma'am, our principal, Dr. Apurva Shimpi sir, and the technical team of PHYSIO TV. Thank you for arranging this session. Thank you.